but there's no evidence regarding, because both, see, remember one thing, clomiphene blocks your receptors. So you have an antihistaminic effect and you're using a completely different compound. I prefer either, I tell the patient very clearly, you have two choices. We can either waste this cycle, or you can have, your endometrium is good, we can try continuing clomiphene, knowing that it will work in some cases. Or I'll start gonadotropins. So, mixed matching, I don't know. I really don't know. I know I'd gone for a lecture a long time ago, and the man was giving clomiphene in the morning, and that was all in the evening. And he said it gave him 100% pregnancy rate, so I said, okay. I said, God is great.
So stents that can be used with letrozole also?
We don't know.
There is no data.
There is no data.
You can try it. There will be no
Remember one thing, if there's a monofollicular growth, you're not causing any harm. And until the way I did not know the steroid protocol. I only tried finding it out because I thought, I can't be that brilliant. I came up with a new regime. I was so happy. But it's been done, and there's a logic towards it. And in the same way, you will know how it works. Give it a try.
Why doesn't tamoxifen have negative feedback? Sorry, adverse effect on cervical mucus and endometrium?
We don't know. It came as a replacement, but it doesn't seem to have the same effect of clomiphene. So it could be because of the product itself, but it doesn't seem to thin the endometrium, doesn't change the cervical mucus. Why, I don't know.
I want to ask, because you have advised us to wait until the follicle reaches 20 or 21 millimeters. So this puts us at risk of having premature luteinization.
Or premature ovulation. Your premature luteinization will happen much earlier.
Yeah. So my question...
There is a risk, and as I said, this is very anecdotal evidence. I tend to wait. Amit doesn't like clomiphene. I'm a great lover of clomiphene, and so we defer there. But we'll show you another talk where we'll tell you which is better. But that is anecdotal evidence when I tend to wait till 20 or 21 millimeter.
Yes, but my question, if we go back to the normal physiology, as you said in the first lecture, we know that in order to have an LH surge, we have to have a surge in the estradiol level first.
Yes.
So if the pituitary thinks that the estrogen levels are low, so how does it give the LH surge? It's not supposed to. So why do we have this premature LH surge? If the pituitary thinks that the estrogen is low.
One of the reasons why oral agents will never give you as high a pregnancy rate as gonadotropins is that you cannot predict when LH surge can happen. LH surge can happen any time between a follicle being 17 millimeter to a follicle being 28 millimeter. Ovulation also happens anytime between 17 to 25 millimeter. So you don't know, and that is that risk that you take. So if you trigger at 17 millimeter, we know that the clomiphene results are worse. Do you wait longer? That is debatable. But you will always have some patients who will ovulate early with clomiphene because you're not blocking it. And that's one of the risks that will always happen with oral agents.
And what do you think about the LH urinary kits? Can we use them in conjunction with...
You can, but there is a 20% failure rate of urinary LH tests. The only way you can get a very good LH level is doing a blood LH level. But it is, one, expensive, and second, you'll have to do it repeatedly. So that's one option is to use a urinary kit. Use one of the CE marked kits, which you can do twice a day LH levels, and it's worth trying. That's what a lot of our patients do. Our patients do an LH level, urine test to check for ovulation, and that's one way of doing it.
But premature LH surge and premature luteinization is such a problem that forget about clomiphene. It happens even in IVF cycle with the antagonist. We've got patients now and again all the time. If you do 2,000 cycles of IVF, you will get premature LH surges. It's not unusual. You go and it's all gone. So that is just, how does the brain escape that antagonist effect? No one understands. But there is a reasonable failure rate of up to 1 to 2%. 1 in 100 will have premature LH surges and premature luteinization, and there is nothing you can do to stop it. That's the problem.
Yeah.
About the Clomid, you said the starting dose anytime. But what about the patient? She had regular but long cycle. To use at day 5.
Let's say if you've got, she has one pill every 3 months, then you have a choice. Either you can start whenever she comes, if there's
No,
no,
I mean if the patient, she had a regular cycle.
yes,
And
then you
she
should
had
not
long
be using,
cycle. No.
then you should not be using chloroquine.
Sometimes there is no irregularity with
I'm very confused.
no. Sometimes I have infertility, even if my cycle is regular.
Yes,
So if my cycle is regular and it's long, so it's come every 35 days, for example. Or
That's
30
normal,
50
28 to
days.
30.
Yes, you know, it's normal.
Yeah.
So should we start Clomid in day 2 or better to day 5?
see, if there's an ovulatory cycle, Clomid does not work.
So first you need to establish that even if that cycle is long, is it an ovulatory cycle or not? And if there is an ovulation happening naturally, then Clomid will not do anything more. Clomid will not improve your. That's the group of patients where Clomid gives the worst outcome and results. Where Clomid will give you good outcome is an ovulatory cycle, long, short, doesn't matter, or PCO women. That's where Clomid has got very, very good role to play. So if you've got regular cycles and ovulation and still not getting pregnant, then I will not do Clomid or the sort of FSH or anything. That's the question. That to me is unexplained. I don't understand why she's not getting pregnant. You've tested her tubes, the sperm is normal, uterus is fine, everything is okay. So that's the group of patient where you will have to say, well, giving Clomid is not going to make a difference. Perhaps timing and IUIs and inseminations might make a difference there, which is a bit of invasive. And if that doesn't, then you'll have to move to IVF. Yeah. Somebody here.
Theoretically, if I'm going to start the clomiphene at day 2, I'm inducing not monofollicular, polyfollicular growth. Because the secondary recruitment
Your
still
aim is
involved.
your aim is to induce monofollicular. The side effect is multifollicular. So some women will have 1 follicle, some women will have 3 follicles. So it varies between how a woman responds, and it's almost impossible to predict our ovarian response on clomiphene.
Or any drug, except for letrozole, which generally does not give much.
If the clomiphene has long life effect, long half-life effect, why we have to use it for 3 successive cycles? Why not interrupted cycles?
Because one is, it seems to work in 3 regular cycles. Secondly, I don't know if my patients don't have the patience to wait 1 month and do nothing.
If I convince my patient.
It doesn't give any benefit. But if you want to do it, you can do it. But it's no benefit. I would rather say that it works very well. You see a better effect if you do it cycle after cycle, and you should do it cycle after cycle.
But your cumulative pregnancy rates would be higher if you do in sort of multiple cycles, one after the other.
Okay, last question. If you have bad endometrium, did you try any of the drugs that are used for enhancing the endometrial receptivity?
One is that they're very expensive. And secondly, you are trying to treat the side effect of a drug, which is already ruined the endometrium. So you should not be doing it.
If we give clomiphene on the 5th day of the cycle, when we scan the patient?
Around day 11.
11.
Yeah. So day 5 to day 9, and 2 days later you scan.
You say that you do not use clomiphene citrate in unexplained infertility. You've not noticed any difference with trying to exploit the multifollicular, if you aim for multiple follicles, and then maybe do IUI, that would not help?
No, if you see that the success rates with clomiphene and IUI is 8%. So
That's what we would like to believe, that if you grow more follicles, sperm will have more targets to hit and all those things. It's a very good sort of talk when you talk to patients. They get convinced. But if you actually look at the scientific evidence, it makes no difference whatsoever. It's, if anything, it's worse even. So unexplained infertility, I generally don't use Clomid unless the patient says that, nope, I'm not going to do anything else but give me something. Then I say, well, it's a wrong treatment, but you can have it.
What about unilateral tubal blockage? Because sometimes some of our patients cannot afford to go for IVF. Would you then, maybe that would help? When at least you hope to get maybe.
I think it's about giving the informed choice to patients. And I think it's, if you have one tube blocked, the one is there could be a tubal factor which could be varied. So you may have a structurally a tube blocked, the other tube may be open but not functioning very well. And I don't tend to do it, but I can understand. You have to tell patients that the chance of pregnancy are lower. Also, there's a chance of ectopic pregnancy. And if the patient still decides, no, I want to do it, it's something which you can decide. It's not completely wrong, but it will have a lower success rate.
Doctor, for the patient she had twins or multiple follicles, I would predict that she will have more miscarriages because of the beginning of endometrium. If she
with 10 endometrium, the evidence says that pregnancy rate is close to 0%.
No, I didn't see 10 endometrium, but she get pregnant, but she had multiple follicles. So can we predict that she will have miscarriage?
If she has twins, 1 in 5 twins will miscarry.
So can we do anything or not?
Have a monofollicular growth.
No, if you already have this.
Then send the husband for abroad.
Can't do anything. I think the main reason for increased miscarriage with Clomid, this is my belief, is because the group of patients where you use Clomid is the women with polycystic ovaries, right? And ovulatory patients. And we will talk in the recurrent miscarriage thing that there is, and also the RCOG guidelines, if you look on recurrent miscarriage, though it's about 6 years old, it tells you that there is a clear association of polycystic ovaries with increased miscarriage risk. Now, whether it is due to high circulating free testosterone, high LH, insulin insensitivity, has metformin got any role there or not, we don't know. But it's the PCO nature of the ovary which increases the risk of miscarriage, and not Clomid by itself, I think.
I don't mean that only by itself. I mean the endometrium will not be prepared well to combine 2 or 3.
No, I mean, but no, you can't do anything. What else will you do? You can cancel that cycle if you're worried about it. But multiple pregnancy is part and parcel of this. It's going to happen now and again. Lady of the yeah.
I was asking about how can you know that it's not functional cycle? I mean, you measure the day 21 progesterone level to say that 50 milligrams was successful or not successful? Or the ultrasound, you just rely on?
Yeah, generally what is advised is do a day 21 progesterone, 7 days after ovulation.
The minimum above 30 means successful?
Yes, if it's low, then move to gonadotropins. See, clomiphene is not a magic drug. It has its role to play, but it will, if you observe it, if you get a low progesterone, it's no use trying to do anything. We know that in those cases, gonadotropins will always give you a better success rate. Okay, so we'll go.